Good morning. I'm really excited to be here. This is actually my first OCD TEXAS Conference, and I'm really honored to be asked to moderate the panel. I'd like to start by introducing my colleagues here on the panel, and I guess we'll go in the order that we have them seated here. This is Dr. Thomas Smithian. Thomas is a postdoctoral fellow at the Anxiety Treatment Center of Austin, where he treats OCD and a variety of anxiety disorders. He is also a postdoctoral fellow at Spectrum, where he works with adults and adolescents with social communication challenges. And beside him, we have Dr. Pete Vernig. He is our most recent member of the Anxiety Treatment Center of Austin. He is a postdoctoral fellow working with OCD and related anxiety disorders. He also has a special interest in social anxiety and dating anxiety. Next we have, who's next in line here? Oh, okay. We have Stacy Nickel. Stacy is in private practice here in Austin. She specializes in the treatment of body-focused repetitive disorders. And you're going to have the pleasure of hearing her speak in a little bit. She's going to talk about hair pulling and skin picking. And next we have Dr. Marianne Stout, who is a counseling psychologist at the Counseling and Mental Health Center at the University of Texas in Austin. She also is a psychologist at the Anxiety Treatment Center of Austin, where she treats OCD and anxiety disorders. Next we have Dr. Leonor Diaz. Dr. Diaz worked with me at UT for a number of years. She is now in private practice here in Austin. She's a clinical psychologist specializing in the treatment of, among other things, anxiety, generalized anxiety, stress, worry, perfectionism. And next we have Dr. Catherine Gorley. She is a counseling psychologist, and she is in private practice here in Austin, and she specializes in treating OCD, PTSD, and a variety of other concerns. So that is our panel. So our topic for today, see if I can find it here, dispelling myths and stereotypes about OCD-related disorders and co-occurring conditions. So each of us is going to talk about a particular issue within this broad topic. Kind of in the middle, we're going to have a demonstration with hopefully some audience participation, and we're going to end up with discussion, questions for the panel, and discussion among the audience. So we're going to start by talking about myths, and thanks to any of you who wrote down some of the common myths over here on the paper, since that's the theme of our conference today. So I'm going to talk about some of the most common myths and try to dispel them a little bit. So the first myth that you all have probably heard is that OCD is all about cleanliness. Well, we all know that it's much more than that, and certainly sometimes cleaning compulsions, washing is a part of OCD, but it's only one part of it, and there are many more other things that relate to OCD. And I kind of struggled a little bit with this topic because I'm trying to determine what are the different subtypes of OCD, and if you go and look on the internet, you can find many, many, many different lists and subtypes and lots of acronyms. So I had decided I just had to tolerate the ambiguity and just go with sort of the 4 or 5 most common ones that tend to emerge when you look at the literature, when you look at the research. We'll be talking about these and other ones as well. So the first category are symptoms that have to do with contamination, obsessions about contamination, washing, cleaning compulsions. That's one of the more common types. Then we have harming, which involves harming obsessions, usually accompanied by checking compulsions. The third most common group is what sometimes is called pure obsessions. These are obsessions that don't have any visible rituals. I think it's really rare to have something that's a pure obsession because often there are some type of mental rituals that are going on. And in my experience, it can be much more difficult to manage the mental rituals. It's much easier to stop engaging in a behavior than it is to stop having a thought. These are sometimes obsessions about religious things, sexual things, violent thoughts. A lot of those are some of the more common categories. The next category is OCD symptoms related to symmetry, ordering, arranging, counting, that sort of thing. And the final one is hoarding, which, as you're going to hear about in a little bit, is now actually a separate category outside of OCD. Myth: real OCD is really rare. I think we all know that that is not the case. Fact: at least 1 in 100 adults experience OCD or have OCD right now in the United States, and that equates to 2 to 3 million adults. That was roughly the number of people who live in Houston, to put it in perspective. Myth: OCD is a woman's disease. Well, I guess if we look around you, obviously it's not only women that are concerned with this issue. Fact: in some age groups, OCD is actually more common among males. For under age 18, males suffer from OCD at a higher rate, roughly a ratio of 2 to 1. So for every one female under the age of 18 who has OCD, there are 2 males who experience OCD. For over age 18, it is more common among women, but it's not extraordinarily more common. It's about a ratio of 4 to 3. So for every 4 females who have OCD, there are 3 males in that age group. The most at-risk age group for women is age 25 to 34, and for males, it is age 11 to 18. So as you can see, women are not the only ones dealing with OCD. Myth: OCD is rare in kids. I think most of us know that that is not the case. Fact: 1 in 200 kids have OCD. That's about 500,000 kids and teens in the United States. If you take an average size elementary school, that would be 4 or 5 kids. A medium to large size high school, you're looking at 20 students who are dealing with OCD. Myth: OCD is incurable. Well, this is perhaps the most damaging myth of all. I think we all wouldn't be here if we thought that OCD was incurable. Fact: 7 out of 10 people will benefit from treatment, and by treatment could be medication or therapy. And for people who benefit from cognitive behavioral therapy, they experience a reduction in symptoms by 60 to 80% on average. The combination of CBT and medication is more effective than medication alone. And the effects of CBT are more durable than the effects of medication. And what that means is that if you you go through a period of treatment and your symptoms remit, and you stop treatment, if you stop medication, you're much more likely to relapse than if you stop cognitive behavior therapy. And I think the reason for that is that with cognitive behavior therapy, you're learning skills that you can continue to implement even after treatment is over. Also, I think the self-efficacy piece is really important. When you go through therapy, you learn that your response to the symptoms is really what's making the difference. Whereas with medication, people might tend to attribute their improvement to the medication rather than to anything that they're doing personally. Myth: people with OCD are crazy. Well, those of us in the mental health world don't like that word, crazy. But what people typically mean when they say crazy is that the person has lost touch with reality. And in fact, it's quite not the case. People with OCD recognize that their fears are out of proportion to the situation or in some way may be unreasonable. And in fact, that's part of the criteria for OCD. And in their calm moments are able to recognize that. But when triggered, it's really hard to get in touch with those more rational thoughts. And even though you may recognize that your fears are unlikely to happen, it's hard to let go of that uncertainty. It's hard to tolerate that uncertainty. Although people with OCD tolerate uncertainty in other areas of their life just fine, if it's their OCD fears, it's hard to tolerate that uncertainty. Myth: OCD is just a personality flaw, people who are picky or fussy or anal. Fact: it's not a personality flaw. It's something that improves with treatment. It's something that causes serious distress, it's time-consuming, and seriously interferes with a person's normal routine. Myth: people with OCD don't have any willpower. Well, I would argue that in many cases it's the exact opposite. The people who develop OCD are not the lazy people of the world. And the paradox about anxiety is that the harder you try to fight your anxiety, the worse it gets. The more invested you are in not having your obsessive thoughts, the more they loom large. So it's really not about willpower at all. And we're going to talk a little bit about what OCD is about. So now I'd like to turn things over to Dr. Smithyman and Dr. Vernig.
Thanks, Diana. As Diana alluded to a little bit earlier, there's going to be a change in how OCD is being classified in the DSM. So this means for the diagnostic manual, which the American Psychiatric Association puts out, they're coming out with a new one. Apparently the current date for it coming out is in, I believe, May of next year. And so the important thing is that the anxiety disorder category, which used to be sort of grouped by disorders of arousal, so very, very high arousal levels, categorizing and grouping these disorders together, that's going to shift a little bit because importantly, I think for us, OCD is going to be moved out of anxiety into its own separate category and group. So it's going to be obsessive-compulsive and related disorders. So its own separate category. There are going to be remaining most of the anxiety disorders, but PTSD is going to be in trauma and stress-related disorders too. So moving to tell you a little bit about that. So OCD no longer groups in with all the anxiety disorders, its own category instead. And the components, you're going to have obsessive-compulsive disorder, also body dysmorphic disorder, and I believe Pete's going to talk a little bit about that. Hoarding, which I believe a few days ago or yesterday there was a talk on hoarding, is that right?
Tuesday.
Oh, it was Tuesday? Okay. So we won't talk too much about that. And then hair pulling, trichotillomania, as it was called. Now it's its own diagnostic category, so it's a diagnosis, as is skin picking, and Stacey will be talking about that in a few minutes' time. So the sort of important pieces about this, and I think it's important to think about why this is being changed, and part of this is to do with as the diagnostic manuals come out with new editions, all the research that's been done in the meantime is helping people classify and group the disorders. So even though there's a lot of overlap, OCD definitely involving anxiety, the research is sort of showing that it fits with these other disorders, and in some ways it can be seen as being a little more distinct. So in some ways the OCD grouping symptoms are unique compared to other anxiety disorders. And largely I think of that as being a lot of it the compulsions, because anxiety always has avoidance. So if you're anxious, you want to avoid what makes you anxious. But for OCD, the behaviors, it looks a little bit less like avoidance. It's a compulsion, so it's a lot more repetitive, more ritualized. So that makes it look a little bit different. There's also a little bit more of a comorbidity, which I think Marianne and Leonore are going to talk about comorbidity. My thinking, though, to sort of just wrap this little piece up, is the benefit of having a separate category for obsessive-compulsive and related disorders is that it gives it more attention. So instead of being grouped in as one of many anxiety disorders, it's really put in its own category, gives it special recognition, special attention, and it's predicted that that's going to lead to more research and more funding, which I think is in the best interest of everyone who cares about this category. So I'm going to pass it on to Pete.
All right, thank you, Thomas. So one of the things that I am going to talk about very briefly is hoarding, which is one of the diagnostic categories that's included as an OCD and related disorder. Now, it's been argued to be included possibly as a subtype of OCD. And let me tell you, if you've ever seen a group of psychologists and psychiatrists and counselors arguing before, it's not a pretty thing, and especially when they argue about diagnosis. But Originally, they were looking at including it, but what we've seen now is that really there are some pretty strong differences that suggest that hoarding should be considered its own disorder. So first of all, some of the cognitions, the thoughts, are very different when it comes to hoarding as compared to OCD. So first of all, hoarders tend to experience less distress than individuals living with OCD. That's not to say they don't experience distress, but the distress they experience at worrying about possibly having to throw things away or what will happen if they lose things that are important to them tends to be somewhat less distressing overall than the distress that somebody experiences in response to the obsessions that they're experiencing with OCD or the behavioral compulsions that they're exhibiting. Additionally, hoarders tend to have more difficulty challenging these thoughts, and they actually tend to have some skills deficits as far as the ability to actually decide, is something an object of value or is it just junk? So skills deficits are something that tends to be unique to hoarding, whereas in OCD, people don't really have skills deficits to speak of. There are obviously the bothering thoughts that can be very intrusive. There are the behaviors that can be very disruptive interpersonally, socially, as far as health is concerned, but there aren't really skills deficits present. Additionally, the neurophysiology of hoarding tends to be different. We tend to see different areas of brain activation for individuals who are hoarders compared with folks who have OCD. There are, however, just to make things a little bit more complicated, there is some overlap with OCD. Hoarding can exist entirely OCD independent, so hoarding just by itself. An individual who is a hoarder can also be diagnosed with OCD. Both disorders can coexist together. And there is also something called OCD-based hoarding. Now, I've never thought that As Good as It Gets is the best example of OCD, but there was a good example in that clip of some OCD-based hoarding when he opened the medicine cabinet and you saw the lines of soaps that he had all set up. Sometimes people with OCD will engage in behaviors that look like hoarding as a part of their compulsions. Now, that's not to say that they have the same thoughts behind that. The things driving it are different, but there is what we refer to as OCD-based hoarding. Now, to talk also about some of the differences, some of the justification for why OCD deserves its own diagnostic category, there are also neurophysiological differences between anxiety that people experience with OCD and other anxiety disorders. Now, I think that this is really cool. I think that this is one of the real benefits of having a new edition of the DSM, the fact that we're actually getting into differential areas of brain activation and how that can help us to tell the difference between different disorders. This helps us to really have a much more solid, much stronger scientific base for the diagnoses that we give, which ultimately helps us to provide more effective treatment. So some of the neurophysiological differences I have to stress, these are preliminary findings, certainly not conclusive, but they definitely are very promising. So there have been shown to be, and there's a rather large body of research in this area. I'm just going to cover two very distinct, simple pieces of it. First of all, the frontal lobe. There's been shown to be greater activation in individuals living with OCD. So the frontal lobe is kind of our decision-making center. It involves higher reasoning, logic, planning for the future. That's the part just behind the forehead and above the eyes. And then also the basal ganglia, which has to do with habit formation. And you can see how the part of the brain that's involved in habit formation along with the frontal lobe could very easily be implicated in obsessive-compulsive disorder. Also, biologically, there's a difference in the psychopharmacology of OCD. OCD and body dysmorphic disorder, which Thomas talked about briefly, involves disorders which are less responsive to non-serotonergic medications. So SSRIs such as Paxil or Prozac tend to be more effective, whereas other medications, OCD just doesn't respond to them the way that other anxiety disorders do, things like benzodiazepines. And finally, there are some forms of neurosurgery that are starting to be attempted for more extreme cases of OCD. This certainly has only been shown to be helpful for cases of OCD and not for other anxiety disorders. So in addition to the cognitive components, we have some distinct biological reasons why OCD should probably deserve its own category in the new DSM. Now this, I won't pretend this is new. People have probably seen this before. This slide is used by almost everybody that talks about the neurobiology of OCD, but they use it because it's such a good one. This is a positron emission tomography scan. Basically, all this does is show overall levels of brain activation over about an hour or so period. And the frontal lobe, the front of the brain, is up at the top. You can see the individual closer to me with obsessive-compulsive disorder, a lot more activation in their frontal lobe than somebody who does not live with obsessive-compulsive disorder. So this is just to show the actual science behind this. We are actually able to look at the levels of activation in different people's brains, in different parts of people's brains, and sort of use that to help to determine what, where the line should be drawn between different disorders and different categories. And finally, the actual criteria for OCD. A few minor changes are being made, nothing terribly major. There's primarily a few things that are being removed from the definition of OCD, which just help to differentiate between generalized anxiety disorder and psychosis. So a couple of points are just being removed. But there is the inclusion of what's referred to as a tic-related OCD specifier. Sorry, that should say specifier. So essentially, what that means is that an individual with OCD who has a lifetime history of a chronic tic disorder can be diagnosed with this specifier. In other words, it is considered to be a part of their obsessive-compulsive disorder. We've long known that there is some relationship between tic disorders and OCD. This tends to be highly familial with an early age of onset, and men tend to suffer from this more often than women do. So that is kind of wrapping up some of the changes that we see in the DSM-5 coming out, as Thomas said, I guess early to mid next year. And I'm going to go ahead and turn it over to our next speaker, who I believe is going to be talking about skin picking and hair pulling disorders. All right.